Okay, in the previous class we discussed about, and please don't talk. In the previous class we discussed about atelectasis, which means collapse of the alveoli. We call collapse of the lung. Then we discussed about ARDS, acute respiratory distress syndrome. Okay. Okay, this two disease, if you want to tell me in simple language, these two disease, what they do is they will not allow the air to go inside. In simple way, they will not allow the air to go inside. That's why whether in ARDS it is filled with fluid, lung is filled with fluid. You understand the pulmonary infiltrate? I explained yesterday. One student asked the doubt. Pulmonary infiltrate means fluid and cells, because of the damage in the capillary epithelium and the capillary endothelium and the alveolar epithelium, the fluid goes out, it fills the lung alveoli, and because of that the air is not going out. You see in the X-ray lung as a white lung. Okay, so even atelectasis, the alveoli is collapsed, so the air cannot enter. Okay, so in the X-ray you will be seeing in these cases air is not sufficiently entering the lung. Okay, now we are going to see certain diseases, okay, where over inflation of the air happens. You understand? Inflation means inspiration. Over inflation of the over more amount of air goes inside. Okay. In other words, the air which went inside is not sufficiently coming out. You understand the meaning? The air is going inside. The amount of air which goes inside, the amount of air should come out. Okay, except the residual air. So the air is not coming out sufficiently. Expiration is affected. In these cases, expiration is affected. So when the expiration is affected, slowly the air gets increased in the lung. So this is called overinflation of the lung. Overinflation of the lungs. So if you see these patients, this is the chest cut section. Okay, this is the lung. Okay, this is sidewise diameter. You understand this picture? I made a chest into two half. See, this is another half. Okay, this is the person chest. I cut the chest in cross section. You understand the image? Okay, because some students told they are not understanding image. You understand? So this is the chest type, and if you want to know, I will put the ribs. Okay, what I did is I cut the chest like this. Okay, when you cut the chest like this, you will be seeing the chest into two halves, right? Yeah, so you made a cut cross section and you are going to see from above. Okay, so this is cross section of the chest. This is cross section of the chest. So when you see the cross section of the chest, the sidewise diameter, lateral to lateral diameter is more than the, this is anterior, this is posterior, then the anterior posterior diameter. You understand this? Okay, so what happens? Yes, in if the person is having over inflation of the air, what can happen? The lung has to expand, right? Lung has to becoming more. So what happen is the anterior posterior diameter increases, because they cannot increase on sideways, it is full because rib is there. So they increase on the anterior posterior side. Okay, so what will happen? The person chest will look like barrel shaped chest. The person chest will look like a barrel. You all know the meaning barrel? No or not? The any your group of students didn't know what is barrel. What is barrel? You know cylinder, gas cylinder. Okay, it is a barrel shape. Okay, so barrel shape means most more or less they have same diameter in lateral and anterior posterior. Okay, that is barrel shaped chest or cylindrical chest. Okay, so in these cases, what are the cases we are going to discuss? This patient becomes barrel shaped chest because of over inflation of the air. Because of over inflation of the air. In other ways, the expiration is not sending the air enough out. So this lead to barrel shaped chest formation. So clinically, you will be seeing the persons having chest instead of increased lateral side, they have like this. Okay, so the chest should be like this. So what happens? They become like this. Understand? So it is cylindrical shaped chest or barrel shaped chest. Okay. So they can't send the air enough out, right? So how they will sit is they sit like this. So they compress the abdomen, and with the compression of the abdomen that creates compression in the thorax. So they try to send the air out. They sit like that. Like that they will be doing. Okay, they keep on doing like that. They want to send the air out. Okay, so this is the another position of the patient. The position of the patient is they will be drooped like this, and they will keep on sending out. If you have a smoker in your house, especially 50 years plus, if you see them, they will be doing like this. Okay, so the chest becomes barrel, and they keep on sending the air out by drooping themselves. Understand? So this is the clinical presentation. Why I am telling this as in the introduction itself, we are going to talk about the condition which causes over inflation of the air in the lung. It is exactly opposite thing we are going to discuss, what we discussed yesterday. Okay, so now let's draw the lung. This is trachea. Don't murmur. What? Yeah. Overinflation means what? That's your question? Okay. So far you didn't understand overinflation, what I explained? Not inflammation. Inflation means any like ballooning up. Huh? Air, if you inflate the air means inflate the balloon, which means blow the balloon. Okay, so that is inflation. Understand? So when the air is coming too much to the lung gets inflated. Okay, so like a balloon. Okay, so it now this is lung. So now this is dividing into primary bronchioles, and they further divide. They keep on dividing, and they form tertiary bronchioles. You all understand? So this they call it as a bronchopulmonary tree. In anatomy, they call it as bronchopulmonary tree. There are segments. They divide them into multiple segments. Okay, they call bronchopulmonary segments. Okay, this oral you should be thorough. So now this bronchopulmonary trunks, they end up in the alveoli, right? See, if you don't understand the diagram which I am drawing, that is an acute problem in the lecture. Understand? So you have to address it as if you are not getting the oxygen. Okay? So immediately you have to address it. Okay? So if you tell me after the lecture, it is like an autopsy. Okay? I cannot do anything about it. Okay? So please inform me if you are not, because I am thinking that you are understanding and I am drawing. Okay? So when I draw, I don't see your faces. Okay? So please tell me if you are not understanding. That's why a little bit I am telling what I am drawing in the beginning. This is trachea. This trachea is dividing into bronchus, and then they enter the lung. They divide into small branches, and they forming the trunk. That is called bronchopulmonary trunk. Okay. Then the bronchopulmonary trunk, they end in the alveoli. Alveoli is the sac. Alveoli is the sac. So now this alveoli is surrounded by the heart, right? So now I am drawing the heart. Alveoli is surrounded by the vessels which is coming from the heart, and you all know the venous side the blood enters from lower part of the body and upper part of the body, right, to the right atrium, then it goes to the right ventricle, then it enters the pulmonary artery, and this pulmonary artery enters the lung. They enter the lung, and they enter the lung, they give small branches. Okay, they form small arteries, pulmonary small arteries, pulmonary small arterioles, then they form the capillaries. Now they forming the capillaries. This capillary is running around the alveoli. This capillary is running around the alveoli. Okay, now once they get oxygenated, they come out as a oxygenated blood, but it is a pulmonary vein, and they come out as a oxygenated blood, and they come out as a pulmonary vein. Where they go? To the left atrium. If it goes to the left ventricle, it is a congenital disorder. Okay, it goes to the left atrium. Okay, then it goes to the left ventricle, then it goes to the aorta. Okay, you understand this circulation? Okay, now let us little bit add certain things in your knowledge regarding the alveoli. Alveoli, if you see, alveoli has septa in between the alveoli. Okay, alveoli has septa in between the alveoli. You understand this part? Okay, this is called alveolar septa. This is called alveolar septa. Okay, this is called alveolar septa. Okay, so I am putting the septa now. Okay, remember the septas have small micro pores, holes. Okay, so through that all the air circulates. When it goes to the alveoli, through that all the air circulates within the alveoli. Okay, so because if alveoli are not having pore, if one part of the alveoli receives too much of air, then they will burst. Okay, to avoid that, we have small pores. It is called pores of Kohn. Okay, so in Chelline anatomy they will take. Now you remember the septas has small pores. Pores means holes. Okay, P-O-R-E-S means small holes they have. It is very micro holes. Okay, so through that the air circulates. Okay, now this alveoli is septas, especially the alveolar wall, kullu wall, it is made up of elastin. It is made up of elastin. Okay, it has collagen also, but mostly it is of elastin. They have powerful elastin fibers like a rubber band. They have a powerful elastin fibers. Okay, now I am going to introduce two terminology. Actually I put it in the video also because it is worth mentioning. So when the air enters the alveoli, okay, when the air is entering the alveoli now, okay, so this hand is alveoli, right? So air is entering, what happens? The alveoli stretches. Alveoli stretches. This stretching of alveoli, in medical terminology we call it as a compliance. C-O-M-P-L-I-A-N-C-E. It is called compliance. If you see any physician, they will be talking in the respiratory diseases. See, this patient's lung compliance is reduced. Okay, like that they will be speaking. So you should know what is compliance. Okay, as if they say, if you ask them, they will not explain to you. Okay, so most of the times they are so arrogant. So what you have to understand is they are have a compliance. Okay, so what is the compliance? Compliance is the ability to stretch. Ability to stretch, because certain diseases affect them, they cannot stretch. They cannot stretch. Okay, now the air entered, okay, then the alveoli is having compliance, okay. After the property of compliance, there is a elastic fiber, right, as if you stretched the rubber band. You understand? If you stretch the rubber band, how much maximum you stretch, if you leave it, that much fast they come back, okay, unless it is not overstretched, okay. You cannot stretch beyond the limit. If you stretch beyond the limit rubber band, what happens? The elasticity is lost. If you see that rubber band in microscope, I'm not serious, I'm not joking, seriously telling. If you see that rubber band in microscope, these are the things I do when I'm studying residency. If you see the rubber band in that microscope, if you see carefully, the fibers in the rubber band is ruptured if you stretch too much. Understand? Same thing happens to the alveoli. If the alveoli goes for overstretching, what happens? The elastic fibers are ruptured. If it is stretched within the limit, then they come back fast. That is called recoiling of the elastic fibers. This is called elastase property. This is called elastase property. So some disease affect the recoiling, that is some disease affect the elastase property. Understand? Okay. So now why this is happening? Because of the elastin fibers. Why this too is happening? Because of the elastin fibers in the alveoli. You all understand this? Okay. Now we will take a person, okay, who is a smoker. Okay, we have macrophages, right? We have macrophages. In the smokers, what happens is they keep on stimulating the macrophage. They keep on stimulating the macrophage. When they keep on stimulating the macrophages releases acute inflammatory chemical substances. Okay, this is basics from POD. So they keep on smoking. They keep on increasing the inflammatory trigger. So inflammation is keep on triggered, but neutrophils keep on coming. But neutrophil releases the enzymes. But neutrophil release the enzymes, and that has a enzyme called elastase. They have the enzyme called protease. These are all very dangerous enzymes because they will destroy the elastin and they will destroy the collagen. Okay, so when these enzymes come, but we have a counter mechanism for this. We have a anti enzymes. Okay, so that will try to balance it. But the person is keep on smoking, that anti protein, that is anti elastase property is lost. Okay, so they become imbalanced. More elastase comes, anti elastase is lost. 1 second, I'm telling. Now let's see the alveoli. Okay, now this is what? Capillary. This is alveoli, this is capillary. Now we have a flat cells, that is what is the cell? Huh? Type 1 epithelium, and this is type 2. Okay, now this is type 1, this is type 1, this is type 2. Okay, type. Now this is interstitium. Normally you don't see the interstitium, right? What is this? This is endothelium. Abroad, actually I am going very slow for your batch. Okay, you have to find time. For group 1, group 2 I am finishing every day that lecture. Okay, so I am purposely going slow for your batch. Okay, now please try to understand, there is a interstitium and there is a capillary and there is a alveoli. Okay, and in the alveoli we have macrophage. In the alveoli we have macrophage, and in the macrophage, if the person is smoking, okay, is smoking, what happens? The smoke comes and they keep on triggering the macrophage. When they keep on trigger the macrophage, then the inflammatory cytokines IL-1, TNF, IL-8 all are keep on released. but somehow we have another property. They try to bring the neutrophil. They stimulate, and they will bring the neutrophil. Understand? Now the neutrophil came, but when the neutrophil comes, the neutrophil releases their enzymes. But when the neutrophil release their enzymes, okay, we have another mechanism which counteracts. Okay, there is another group of chemical substance. They are called alpha 1 antitrypsin. Alpha 1 antitrypsin. Okay, so this protein, okay, this chemical substance counter the elastase. Okay, counter this enzyme which damage the elastin. Okay, so this should be in balance. This two should be in balance. Okay, what happens in the smoker? This is increased. This is increased. You understand? If this is increased, what happens? This elastase will destroy the elastin. This elastase will destroy the elastin, and what happens to the alveoli is this septa is lost. Understand? The septa is lost. Okay. Now alveoli is like a big balloon. Alveoli is like a big balloon. So they are overstretched because elastin is lost. They cannot recoil back. They cannot recoil back. So they have overinflation of the lung, and expiration is affected. You understand? Expiration is affected, and we do a test called pulmonary function test. Actually, if you girls keep on talking, actually you will not understand. Okay, and you girls are going to disturb the girls who is listening. Okay, and actually I keep on telling this. I don't know. Okay, now where I am. Okay, they do a test called pulmonary function test. In the pulmonary function test, we measure the lung volumes. We measure the lung volumes, and when you measure the lung volumes, characteristically one type of lung volume will be reduced in this group of patient. Okay, what is that? Force expiratory volume at 1 second. Okay, forced expiratory, they will ask them to forcefully expel the air. Okay, in the test, forced expiratory volume at 1 second, the first second is reduced. It is reduced. Understand? So in this patient, the inspiration is not affected. This is reduced, the inspiration is not affected, and total lung capacity or total vital capacity will be normal. Why? Inspiration is not affected. Okay, so this gives you a idea what you are dealing with. The person will have a full overinflated lung, and they will be doing him the pulmonary function test, and the pulmonary function test will give you the answer that forced expiratory volume is reduced and total lung capacity is normal, which means there is some problem happening in him inside the lung, that air is not coming out properly. If he is a smoker, you have to suspect this condition. So this condition causes dilation of the alveoli due to destruction of the septa, because of imbalance between the elastase and alpha 1 antitrypsin. Okay, so they will destroy the alveolar septa, then alveoli is dilated and alveoli is not recoiling, so they cannot expel the air out. So this is called emphysema. This is called emphysema. Okay, this is called emphysema. So this is comes under a group of disease called obstructive pulmonary disease. This comes under a group of disease called obstructive pulmonary disease. Emphysema will not happen in one day. It takes years to happen. So it is a chronic obstructive pulmonary disease. It comes under the group called chronic obstructive pulmonary disease. Okay, it's commonly called as COPD. Okay, now in this patient he gets lot of inspiration, right? So he get inspiration, so he cannot throw the carbon dioxide out. Okay, he cannot throw the carbon dioxide out. So initially this patient will be pink in appearance and very lean. They become very lean, and they are called pink puffers. They are called pink puffers. Understand? So, and they, if you see them, very lean person, okay, with barrel shaped chest, and they droop like this, and they have difficulty in sending the air out, and they will be very pinkish in appearance, and they will be very lean. If you see them, you can, by seeing them you can say it is a emphysematic patient. Okay, he is having emphysema. And if you do the pulmonary function test, and you can see the values of forced expiratory volume at 1 second is reduced, and total lung capacity is normal. So with this you should think that because of smoking the macrophage is stimulated, and they keep on stimulating the neutrophil, and elastase is increased, and alpha 1 antitrypsin is not increasing, right? So it's become imbalanced. So it has, the alveoli is destroyed, elastin property is destroyed, so the alveoli is getting overinflated, it is not coiling back. So this is a scenario happening inside him, that your brain should think, then only you can properly treat the patient. Okay, so now this is comes under a disease called chronic obstructive pulmonary disease. Now you all know the bronchi has glands, right? And they also have muscle fiber, right? They also have muscle fiber. Okay, you all know this bronchial glands secrete mucus. Okay, they secrete mucus which coat the bronchus. You all know this, right? We discussed in the basics part. Now what happens is, in the smoker, okay, smoker irritates the bronchi. It stimulates the inflammation in the bronchi. It is called bronchitis. Itis means inflammation. It is happening in the bronchi. When the bronchi goes for irritation, they increase their glands. They increase their gland, and they increase the size of the gland. Okay, which means they secrete more mucus. They secrete more mucus, and the mucus will block. Mucus is a thick. Okay, the mucus will block, and more mucus are produced. Okay. Yeah, so we are talking only in case of smoking. These two things happens particularly in smoker. Smoking is the main cause of triggering this event. Okay, so if you see, if you have any smoker in your home, if you see when they, for example, 20 years of smoker, when they, if you see, notice them when they morning, if they get, well, they're getting up for Fajr Salah, you can see them. You can, if you are sleeping, it will, they are the big alarm to us, because when they go to the bathroom, they keep on coughing out, and they keep on removing the sputum. If you see their sputum, it will be little bit dark gray in color. It will be dark gray in color. Why? Because when they are sleeping, all the mucus get collected at the base of the lung. When they got up, they immediately they take it out, otherwise they cannot breathe. Okay, so they clear the mucus. Okay, so in the long standing case, this mucus will causing some obstruction. Okay, when there is obstruction, remember, the inspiration is not affected, expiration is affected. Inspiration is not affected, because inspiration happens due to negative pressures which is happening in the lung. Okay, they literally suck the air from outside. So inspiration is not affected, expiration is affected. So when again they give the result like this. Okay, force expiratory volume at 1 second is reduced, total lung capacity is reduced. But here the pathology happening at the bronchus level. The pathology happening at the bronchus level, whereas in emphysema the pathology happening at the alveolar level. The pathology happening at the alveolar level. Remember this kind of obstruction, when it is going to be chronic, this inflammation will create fibrosis in the wall. So this wall will be actually narrowed. This wall will be narrowed. It is called obliterance. This is called obliterance. Okay, when the wall is narrowed, it is fibrotic, it is becoming permanent. It is becoming permanent. That's why emphysema happens due to destruction of the elastin. Once the elastin are destroyed, we cannot bring back the elastin. So even when the fibrotic happens in the bronchi, it is permanent. So obstruction happening in chronic bronchitis, the destruction of the elastin in emphysema, this will cause irreversible COPD. They are called irreversible obstructive pulmonary diseases. Okay. Once this event happens, you cannot reverse it. You cannot reverse it. So this is called irreversible obstructive pulmonary disease. Come again. Be louder, Annie. Come on. Contraction. Yeah, see, it will leads to, this obstruction will lead to resorption atelectasis. This obstruction will leads to resorption atelectasis. See, contraction atelectasis happens when there is fibrosis in the interstitium, okay, or in the pleura. Here the obstruction happens at the bronchi level. So the slowly what happens, the residual air is resorbed, they go for resorption atelectasis. Okay. Aya, can you tell in Arabic? Because this is how I do in dental, for dental students, because some students they can't understand whatever the way you explain. Okay, they need some Arabic assistance.
جزء بنات الدكتور اتفق معايا إن بعد ما نخلص المحاضرة أشرحها بالعربي. فهمت اللي هو قاله ولا لأ؟ لو مش فاهمين يعني فهمتوا ولا فاهمينها ولا لأ؟ يديري؟ أول ما دخل تعالي بتقولي هو امبارح لما شرحها لي النفس المدخل لما بيجي ديت عبارة عن يعني حاجة زي بروتين البروسيس لما جاي يفهم الاستراكشر بتاعها كان فيه هرمون ديت بتروح عشان الضغط اللي هو رسم الضغط اللي هو الأندروجين ديت المفروض الهرمون دي بتطلع زي سكريشن موجود في النفس الشخصي دوت هيكون بتطلع البروسيس غير اللي هو هتطلع زي سكريشن هيخلي ان نفس هيعمل زي ابستراكشن لل ايوه هيحصل دوت ممكن يعني يكون سكريشن يتحول ايه؟ ده لان السي اسمه عشان اعمل الانسبيريشن ما يتأكد فالانسبيريشن ما بيطلع فيه لا يعني نفس الجلاند الموجودة في البرونكا بتطلع سكريشن بيروح اسمه نوبة فبيروح يعمل زي ديسكريبشن لنفس Doctor, I asked them what they didn't understand and they told me that they explain it like it. Yesterday you told me it's the gland, it's a secretion, it's a thick secretion, it's called a mucus, which is abstract progress.
Okay.
So I explained it to them. They told me that.
Okay, actually, I suggest the students who understand and really, if you want to benefit your friends, okay. So we started for dental students in the beginning when they, because dental students we handle them for 1 year, okay. So in the beginning the students are not cooperating because they are scattered, so it's a problem all over in among Muslims. They don't come as a Jama, okay. So but Alhamdulillah, what we did is we made them to unite for good cause. That is, good student, bad student. Not in the. I'm not dividing them on the basis of behavior. Okay, because I don't know you guys. Okay, so on the basis of understanding the subject, I'm telling them. Okay, they got the what I'm expecting. So that students help the students who don't know, who is not able to understand because of language. So they discuss them, and during the 12 to 1 they discuss them, and after that we made it as a regular process. Okay, it's not an optional process. So we identify the students who have very less linguistic skill in English, and that student has to attend. The student who is discussing, they will come and report me. If you want, we can do it like that. Okay, so I will select the student who can able to moderate this discussion. So inshallah, within that day itself, it really motivates them. Okay, so it will help them. So I need support from few students, especially from group 1, and you can include group 2 students as well. So okay, so you understand? Yeah, go. Okay, and so you understand this. I prefer better you guys do this. It will benefit you also, the person who is doing, because they become master in subject. Okay, in such case, such any students is involved to help the student. See, like actually you are helping yourself, to be frank. You are not helping others. Okay, in two ways, your subject get matured, and another way is Allah will reward you. Okay, in some other way. Understand, whether in this dunya or in akhirah. Okay, so if Allah rewards in akhirah, I prefer that. Okay, so understand. So if interested student, they can come regularly to my office by 8 o'clock, because I want to make them more mature in the subject. Okay, so that they can handle your questions. Okay, so let's try this for this module. If it is workable, then we can make it as a regular process. Okay, so this is about two disease, emphysema and bronchitis. This both are chronic condition. Emphysema is a chronic condition, and bronchitis happening in this also a chronic condition. It is a chronic bronchitis. I will take the questions. Just let me finish. So then, in chronic bronchitis patient, okay, they are called blue bloaters. Why? For unknown reason, this chronic bronchitis patient are obese. We don't know exactly why. They are obese and they become blue because obstruction is happening. So slowly, if they will take, when they become permanently fibrotic, the air entering is reduced. Understand? So they become more cyanotic. Understand? So they are called blue bloaters. Okay. This now both happens due to smoking, right? And majority of the cases they have both the pathology. Understand? They have chronic bronchitis with emphysema. Okay, if they have chronic bronchitis with emphysema, the prognosis is very bad. So if they have only emphysema or chronic bronchitis, it is little bit better. Okay, and remember, if you ask the COD patient, they prefer dying. Understand? Because they cannot walk, they cannot take, because they are not take enough oxygen is not going to their blood. Okay, they suffer a lot. So if you are smoking, please stop smoking. Okay, some girls, even shisha is 1,000 times worse than the cigarette. Okay, so don't spoil yourself by thinking you are going to become modern. Okay, so now coming to the understanding of these diseases, remember clinically many of the times we see this both pathology happening in that patient because the common factor is smoking. The common factor is smoking. Okay, so this is what are the things which we discussed now. Okay, you should not forget in your life. Okay, so other things in the slides for only for the exam purpose. What we discussed, that's why I took the whole discussion from the clinical point of view. Okay, so you remember these two things happens most of the times in a same patient. Okay, now this person is having, this is the bronchi. Okay, I'm drawing this bronchi, and he is having some block because of chronic bronchitis. Understand? And you all know these guys, smoking guys, and even smoking girls, smoking human we call it. Okay, the smoking human, and they will lose their cilia. They will lose their cilia. When the cilia is lost, okay, they get lot of infection. They get lot of infection. When they get infection, this will add up here. Okay, they become mucopurulent. They become mucopurulent. Purulent means pus. Mucopurulent, and they become strong obstruction. Okay, obstruction gets stronger. When the obstruction gets stronger, but when the person is inhaling the air, they cannot go down, right? So this causes dilation of the bronchus. You understand? This causes dilation of the bronchus. This is called bronchiectasis. Ectasis means dilation. Bronchiectasis. Okay. So what happens is, if in this stage you have to somehow remove this mucus. Sometimes we put suction. Understand? Negative suction we give and we keep on removing it. If you go to the respiratory ward in the any good hospital, you see all the patient in the side they have a suction apparatus. Okay, we keep on taking the bronchus. Okay, so and you understand. So in this stage you remove it, this dilation becomes reversible. If the patient is not coming to you on correct time, this bronchi has elastin fibers also, and they have muscles, right? They have muscles. This will be destroyed. This will be destroyed. When there is destruction of the wall, again inflammation comes and they produce fibrosis. Once fibrosis happens, it is permanent dilation. And remember, this is called bronchiectasis. Then the fibrosis becoming so severe and they completely narrow them. Okay, this is called obliterance. Let's go stepwise. Now there is a bronchi. Okay, just imagine yourself, there is a bronchus. Okay, now here there is a block. Now the person is taking air. Okay, and air cannot go down. So this is the proximal part, right? Okay, above the block is the proximal part. This proximal part goes for dilation. If you clear it, then the dilation becomes normal. If you don't clear it, then it gets more dilated. There is disruption of the elastin and the muscle, create inflammation, fibrosis sets in. It is permanent bronchiectasis. Okay, and then it is going to be continued. They produce severe fibrosis and they will narrow down. Obliterance happens. Understand? So this is called bronchiectasis. Okay, this all comes under obstructive pulmonary disease. Okay, now when I told obstructive pulmonary disease, just without if I am not explaining restrictive pulmonary disease, it is incomplete. Okay, we have a separate lecture on restrictive pulmonary disease, but just I will tell you. Yeah, I'm coming, sir.